thank you again for dialing into today's episode of the New South Wales Health Statewide Biobank Seminar Series, and it's a pleasure to welcome Associate Professor Kevin Spring, who is our speaker today. So Kevin did his PhD in Queensland at the Institute for Molecular Bioscience. We actually did our PhDs in Queensland together, although not at the same institute, so we've known each other for quite a long time. After his PhD, Kevin undertook postdoctoral research for a number of years at what's now known as the Berghofer Institute and what was known then as the Queensland Institute for Medical Research. So Kevin worked with a number of investigators. He worked with Martin Lavin, Kumkum Khanna, and Barbara Leggett, and he studied DNA damage responses and particularly in colorectal cancer, including microsatellite instability in colorectal cancer. And then in 2013, he actually came back to New South Wales to the Ingham Institute for Applied Medical Research and Western Sydney University, where he is based now. A lot of Kevin's research continues to examine colorectal cancer, more specifically circulating tumour cells and free nucleic acid, circulating nucleic acids in the context of colorectal cancer. But Kevin has also developed interest in biobanking. He joined the Cancer Institute New South Wales Biobanking Stakeholder Network in the early 2010s, I think about 2014, and we started working together on biobanking at that time. And so today he's going to be telling us about his research interests in terms of real-time data linkage and management for biobanks and translational research. So Kevin, I'll hand over to you. Thank you very much again for agreeing to talk to us, and we're really...
work because I didn't enable my video.
Yep, so just a reminder, everyone else jump on mute and Kevin will start. Thank you, Kevin.
Okay, thanks very much, Jenny, for the kind invitation to present at this seminar series. And you're quite right, our history goes back quite a long way, and it's very nice to see that our paths actually came back together again and continue to do work. As you would have guessed, that data management is not really my forte. But I do have an interest in it, and it really has been spiked through the involvement through the Biospecimen Stakeholder network, and my own interest in biobanking as a resource for researchers. So my talk today is really going to, I suppose, focus around that journey that I've taken around this area and where we've gotten to lately. But first of all, I just wanted to say that I attended the ISBRS meeting in 2013, which was in Sydney, and it was at that meeting that I actually had this light bulb moment, and really the penny dropped, and that was really about the importance of electronic clinical data management systems. So there was a talk that was given then, and I think Nick Cetus was at that meeting as well, and we had discussions about this later, and I thought, you know, we really need to be using electronic systems to capture clinical data and manage that information very well. Okay, so one relevant thing that I wanted to bring up, and I don't know whether people know about this, during the COVID-19 outbreak, the clinical trial studies on hydroxychloroquine, which were being performed and also quite controversial, which ended up in the Lancet and New England Journal of Medicine publishing a couple of papers, which they then retracted. And there was a sequence of events which occurred around this, so these came up very quickly. But really, the root cause and problem about these studies was questionable data sets and question about the integrity of those data sets. And in the end, the authors were unable to complete an independent audit of the data. So I think it really underlines the importance about clinical data and how you use it, how you manage it, and how it is managed in terms of its integrity and governance. So what can actually happen is that this was a failure of data governance and research integrity. And so you end up with reputational damage, and it's something that none of us want. And I'm sure the Lancet and New England Journal of Medicine are very embarrassed by what actually occurred. And I believe that the authors aren't too happy as well. And I'm of the understanding that some of the authors have actually lost their positions within their institutions based on what happened with the publication of that data or dodgy data. So I think maybe I don't need to overemphasize why it's important to have a clinical data management platform. And really the thing about it is that it follows best research practice and meets the increasing responsibility of institutions to provide researchers with secure platforms for data management. And I think this is really important. I actually believe that it's not really up to the researchers, but it's up to the institutions to meet this responsibility. And in 2019, the NHMRC, ARC and Universities Australia put out this guide about management of data and information in research, and it's about the responsible conduct of research. And if you have a clinical data management system, it enables you to protect highly sensitive clinical data and subject data in privacy in accordance with HREC and also the Privacy Act. It addresses a number of different issues around ownership, stewardship and control of that data. It enables you to properly manage storage, retention and disposal of that information and also the specimens, and it provides safety, security and confidentiality. Also, if you've got a electronic data management system, it allows you to give good access control and also provides audit. Right, so many of you would be aware that biobank data management systems have been in existence for quite a while, and they're really key to effective and efficient translational cancer research, clinical trials and also drug development. Most data management systems are LIM systems, which is a laboratory information management systems, and they underpin the activity of biobanks. You enable sample tracking, QA, QC, you can do consent tracking and also sample inventory. You can also enable molecular and clinical data integration and provide some degree of audit. Querying of samples is an important aspect as well, but sometimes querying with these systems is not so easy, as along with network development. So really, data management systems enables more efficient and effective biobank operation, networking, and also supports an open access policy. So if we look at the Biospecimen Stakeholder Network, which was a community of practice committee set up by the Cancer Institute in New South Wales, we undertook a BSN Biobank project, which was funded by Cancer Institute, and it was around the IT infrastructure. It was one of 3 sister projects, and Jenny was the champion of another one, which was about harmonisation, and Susan Goody was a champion for the imaging one. So we ended up putting together a report about data management systems and practices within of the Cancer Institute New South Wales biobanking network. We submitted a 144-page report, which is available on request. It's a bit hard to send around, but it's there. It's got a lot of information in it, and it's quite useful. So this study involved face-to-face interviews. There was a survey process, and a data dictionary was developed that was really to ensure interview consistency. It was piloted with 3 biobanks and then rolled out to all of the identified biobanks. We performed a data analysis and then submitted the report in January 2015. So you can see the flow diagram on the right there, showing the inclusion criteria, the catalogue, of biobanks, the development of survey tools, feedback, and also I'll go back there as well. So these were the other sister projects as well, but I'm just going to focus on the IT data analysis of that report. So what we found that there were 24 cancer biobanks that were identified, and 23 of these were associated with TCRCs, with City Catalyst hosting the most of those biobanks. They had 12 of the 23, which is shown over here. The other one was the Cancer Council Biobank. Sydney West also had a number of biobanks associated with their TCRC as well. So when you look at the data managed systems that were associated with these biobanks, this was varied across the board, and it went from paper through to very basic databases, through to much more sophisticated ones such as Cansto, and also commercial ones. So the spread was quite enormous, but Cansto was the one which was associated with Sydney Catalyst, which had the most biobanks associated with a system. So if you look at the type and location of these systems, the majority of them were commercial. There were 14 that were commercial, but they were essentially mostly the Cansto ones. There were 4 open source systems, and then other systems which were a bit unclear about what actually was happening there. I think in those cases they were actually in the process of trying to get together their data management systems. And I think so this also reflects the fact that historically biobanking has been very much a underfunded cottage industry. So being able to have high quality data management systems is not easy to achieve due to the expense. So when you look at the location, most were sitting on institutional servers, some were with hospitals, and others, which is a bit of concern, were either on local desktops or sort of other mini servers, and some, and I think one didn't know. Okay, so when you look at the biospecimen type and number that were associated with this, 70% of the biobanks collected a single tissue type, while the others collected multiple tissue types. And you can see there's a wide variety of cancer types or tissue types associated with this. I think this here just shows the extent, the 30%, which has multiple different cancers associated with it. So the number of specimens those biobanks held were quite varied as well, but the majority of them held between 500 and 10,000 samples. I think as this now is about 5 years old, this data is a little bit out of date, and I'm sure that the biobanks have increased that number quite considerably. When you look at the data capture, you can see that across all of these different biobanks here on the top, there were a lot of different data items which were captured and stored with these biobanks. And again, Sydney Catalyst and these ones here are essentially the Cansto ones, which have got a reasonable amount of coverage for those things, which is consistent. Whereas with the other biobanks, there's a lot of variability in the data items that were captured. But one of the questions around this is how this data was captured. So was it manually collected and entered, or was it automated? We also looked at mapping of the data fields and found that the data was highly fragmented across the biobanks and also was very incomplete. The data vocab standardizations, would be extremely useful, but so this has a limitation because the data capture is limited by the hospital data source systems and how they capture their systems and what sort of vocabs they use. But you can see here in red, in this box here, I'll just expand this out so you can see the amount of data that was actually collected. and this comes into focus here. And these are all of the data items, and you can see all of the gaps through this here. I'm not sort of saying that we're able to or should be able to collect all of this data. I think it's actually impossible to do, but we should be able to sort of get greater coverage than what was the case in 2014. If you look at the data dictionaries and the minimum information standards that were used, so it's gratifying to see that sort of 16 of the 23 biobanks did use standard vocabs and dictionaries. There were some which didn't, which I'm not quite sure why that would have been the case, and a few others which didn't know as well. With the information standards, most didn't sort of adhere to any of the other guidelines which were given out by different organisations, such as Cancer Australia dataset specifications, or even the ICD-10 guides. And if you look at the data linkage and entry, most biobanks did not have any electronic data linkage at all. So I think that was 19 of them had none, and just I think 3 had some form of data linkage or communication. So yeah, so one of them actually had tried automated weekly data extracts, but in the end reverted to doing the manual extracts. So creation of manual extracts from the source systems, and then manually sort of uploading them to the biobanking database. And therefore, the mechanism of entry was mainly done by hand. And so manual data entry is extremely time-consuming, and is something that we should be getting away from and freeing up biobanking staff to be able to do other things or do their called biobanking duty. Because this takes an enormous amount of time, and also it's prone to error. If you look at the non-machine readable files that biobanks tend to have as attachments, they go from pathology reports all the way through to consent forms and the imaging data that's associated with them, whether they be H&E sort of files or MRI images, etc. And the file types are mainly PDFs, but also JPEGs, and also these imaging files as well. So there's a lot of attachments which actually happen with biobanking. And when you look at the data security, 14 of the biobanks had secure servers and also restricted access. There are other ones which had access restrictions, but I assume that they were not on secure servers. And a few of them,
in addition to one first author empirical collection, one submitted.
No. If you can mute your microphone, that would be great. And 3 others didn't have or didn't seem to have any, but they were really because they were starting up their systems. So just to summarise this section, we had identified 23 cancer-related biobanks. This may have increased now. The operational IT systems really occurred in an uncoordinated manner, apart from maybe Sydney Catalyst with the CanSto system. And this is constrained by the clinical and research environments of each biobank. Data linkage was minimal, and the data was entered mostly by manual process. The data sets were incomplete, they were fragmented, and they lacked a lot of standardization. However, one good thing about this was that there was an appetite for data harmonization and also the development of cross-biobank minimum data sets. Right, so from that report and the continuation of the work of the BSN, we undertook another study, but we'd like to say that, most of the cancer biobanks have made really great operational improvements in recent years. However, there's still a gap in the ability to provide a comprehensive clinical data annotation, and that really is due to a lack of data linkage. And I think we all agree that clinical data is recognised as essential, and biospecimens without strong clinical annotation are suboptimal for translational research. And this is becoming increasingly important, especially with funding bodies like NHMRC, who is I suppose, directing much more of the focus on translational or clinical research. And again, as I said before, most biobanks manually enter their clinical data or perform a non-automated clinical data upload. However, with the advances in information systems and closer clinical and research relationships, the opportunity for near real-time data capture does exist today. So we undertook another BSM project, and that was first championed by John Permander and then myself, and was funded over 2018 and 2019 to examine near real-time clinical data linkage. And so I'll go through the results of that sort of fairly quickly. Okay, so one of the first things that was done was defining a biobank minimum data set. And this was really based on the minimum data set which was produced by Anna DeFazio as part of another BSN project that she was championing. And it also included the common data variables that were requested by researchers. And that involved these 6 groupings, and they were the patient-level demographics, previous or concurrent malignancy, primary episodes, treatments, recurrence, progression, and relapse, and also the survival data. This is the data sets here, but these are just the broad headlines, whereas they break down into much bigger data sets within each of these groupings. Okay, so when you look at the availability of the data items, and they were mapped against LHD-based data systems across 4 different sites. So 44 to 60% of the data was confirmed as being available, with 8 to 42% as possibly available, and this is shown here. And these were the different sites that were involved in this study, with the Hunter New England, HCRA, Sydney Vital, Concert, and also TCRN. And interestingly, some of the sites didn't have access to the Oncology information system, and the consistency of their data varied, and that goes from defined data sets to free text in clinical notes. So when you're dealing with free text, it makes it much more difficult to pull out the data. And also with the defined data sets, if you don't have a consistent or standardized vocabulary, it makes it very, very difficult to pull that data in a consistent manner. If you look at the source systems and the access that's associated with the different LHDs, in Southeast Sydney, the pathology systems they use is Omni, they use PowerChart for inpatient, and also Mosaic and ARIA. I think ARIA are used in Southeast itself, whereas Mosaic is used in the Irrawalla Shoalhaven, which is also part of Southeast. Southwest Sydney used PathNet, PowerChart and Mosaic. Hunter and Northern used OSLab, and also IPM CAP and PowerChart for inpatients, and ARIA. So you can see that there's a great variety of different source systems that are used in the different LHDs. And if you look at the access, most people had access to the information, but there are some, Sydney Vital had indicated that they did not have access to the Oncology information system, and also had limited access to pathology, whereas Concert had somewhat limited access to pathology. But however, this is now different, and you could say that we have full access to pathology as well. So this is actually good, and I believe possibly Sydney Vital also may be sort of on the way of getting access to the Oncology information system. Okay. So we did a electronic clinical data extraction case study, and we used our concert system or a network to do that. And we did this based on automated clinical data extract using the defined minimum data set from the Southwest Sydney LHD. The data source system that we used was Mosaic, and for pathology was PowerChart. And the, Concert Biobank data management system was Cetus Lab Matrix, which we've been working on, and I'll talk about that in a little bit later. And this is the process that we went through with the data linkage process, where we used our system to pull out input the patients, which which allowed a request for the patient identifiers to go into the database, which we returned the patient identifiers, which then got sent out through a sync and share app called Content Locker. These were then sent to the LHD databases, which then allowed the extracts to be pulled out, and they were returned via Content Locker again, and then ingested back into the Lab Matrix database. So when you looked at the minimum data set availability between the two systems, for the data that was being pulled directly from the LHD, we found that there were 17 data items that were missing, or 22% of all of these here. Whereas when we looked at the Concert Biobank and what had been previously put into the Biobank manually for those patients that were used in this case study, that were randomly chosen from the Biobank, we found that there were 38 data items that were missing, or 50% of them. So you can see that pulling data electronically can increase the completeness of your data. So one of the things about accessing clinical data, you have to have HREC approval and also local health district data custodian approval. And the data custodians release the data in accordance with the policy directive of the New South Wales Health, which is this one here, disclosure of unit record data by LHDs for research and contractor services. And we find that sort of most biobanks really are able to negotiate the local regulatory requirement of HRECs and also LHD. However, the National Death Index data requires separate ethics applications through the Australian Institute of Health and Welfare. And this is a complex multi-step process with long timeframes. It could end up taking up to 8 months. As part of this study, we put together a flow sheet about that process for being able to get hold of the National Death Index, which is available from that report as well, if anyone would like to look at it. So in summary for this section, we were able to define a minimum data set and map their availability. And this data really should be available and useful for biobanks. There's considerable differences which exist across LHDs as to data systems and access to the EMR for clinical annotation. Our case study demonstrated that you could have a model for automated extraction of clinical data from source systems, and the availability of that minimum data is greater via direct linkage, as opposed to being manually annotating that data into the biobank fields. And lastly, for this, access and regulatory approval really can be challenging, but I don't think it should be a barrier that should stop you from getting a lot of this data. So finally, what I wanted to do was just go over what we have been doing in concert as well in terms of addressing the data management issues for annotating clinical data. So as part of the concert TCRC, we're looking at a system which we have called Cetus, which stands for Clinical Translational Informatics System. And these were the requirements and attributes of the system. The scope of it, we wanted to be able to cover the complete network, which included the South West Sydney LHD and the Illawarra Shoalhaven LHD. Access needed to be highly secure, but also available. So we're using a secure web browser-based interface via a VPN and also multi-factor authentication. So the integration requirements were that it needed to be dynamic, near real time, and being able to capture that information from both Mosaic and PowerChart. It doesn't mean that it's restricted to this. The integrations could be extended as well to other data sources. And we needed good access control and audit that allowed you to ensure that you had good compliance with patient consent ethics and regulatory guidelines. The other thing is that we wanted to be able to achieve ethics approval, and so we wanted to have the data management to have HREC approvals. So the activities that we were looking at in terms of supporting was to have a system which was designed to be flexible and scalable and within a single holistic platform that was able to support biobanking, translational research, which was either prospective or retrospective, and you could also support investigative-driven clinical trials, and also set up a registry as well. So there's many different things that the system that we designed can actually support. So that gives it a lot of flexibility for different users to use the system. So this is a list of advantages for users. I'm not really going to go through it, apart from saying that it does really avoid this laborious manual data entry. You can set up these fully partitioned individual project domains, and it provides you with a lot of transparency and reproducibility, and it allows you to do good audit tracking as well. So this is what the system looks like. These are core capabilities here, which based on study, which is the patient information, and also, I suppose, the structure of the different studies, the subjects that are put into it, and also the biomaterials associated with it. So that sits within our system, Cetus Lab Matrix. You can also link via data loaders and APIs different of those systems as well, including CTMS systems as well, which are associated with clinical trials. You can value add the information by having dashboards and also having queries to explore that data. If you have a look at the architecture of our system, this is how it looks. You have a user interface here, and then a series of separate studies. This can be 1, 2, 3, or more. And what we did with this system was put in a number of upstream and downstream switches to be able to regulate the flow of data. So this is an upstream switch here, which comes from each study, where you can actually shut off this feed in terms of the patient IDs, which would then go into the universal study, which underlies the whole system. And part of that is really about, if you've got a continuous data linkage, that will go on forever, unless you have some mechanism to be able to shut it down. So we built that into the system, and it's also linked to HREC project approval start and finish dates. If someone also wanted to stop the data feed at a certain point for specific analysis, they can use this mechanism to do that. So the patient IDs go into the universal studies. Then what happens is that the system generates patient IDs which either go to South West Sydney or Illawarra Shoalhaven, and that is uploaded into the cloud. And then it is sent separately to each of the LHDs and sits within separate folders, which then allows the pulling of data from both Mosaic and PowerChart for SWS and LHD. These go back into a folder, which then go back down into Kiteworks, up into the cloud, and the same thing happens for the islet. Once it gets back into the universal data, then the data can be distributed to different studies based on their ethics approvals. If they have got ethics only for histopathology, that's all they'll get. But if they've got ethics for medicinal treatments or radiation treatments and histopathology, they'll get all of it. So that way we are able to dynamically feed a lot of data to different studies based on their requirements. So these are the data loaders that we've established. So there's histopathology reports, medicinal treatments, radiation treatments, and clinical notes. And these are all of the different groupings here. These also expand out, which contain a lot of information which actually gets pulled back. So we are also able to generate automated notifications from the system, so they can be sent by email to different users if they need to have an alert sent to them. In this case, so if you've got a consent withdrawn email, which can be automatically generated and sent to the appropriate people. Okay, so this is what our access page looks like. And from this part, I'm only going to show you dummy data for this. So once you get in via VPN, this is what you see. Then you can actually link into your study domain, and in this case, I'm just showing you Concept Biobank domain and what it looks like. So you have a series of tabs across the top here, and in this case, we're looking at a general tab which gives the information on the patient and subject. This is the biomaterials tab, which lists all of the biomaterials which are held, or the containers which are set up for collection of samples. So we move then to a Followup tab, which you can enter data into about follow-up information on that particular subject. You have also biobanking attachments within the next tab along, which you can see, might be a bit difficult to see, but there are different things that you can attach to the system as well. In the Forms tab, these are the ones which are associated with the data loaders. So these are the bits of information which are being pulled in from the source systems. In this case, this is a histopathology report, and then this is a medicinal treatments report. So you can actually accumulate a longitudinal series of reports on that particular subject. So you can have a full history of the medicinal treatments. The same goes for radiation treatments, and I think in this one, this is a clinical notes tab. So whatever goes into clinical notes gets reflected in here as well. So you can pull out that information. The thing about clinical notes is that it's usually free text, so it's very much more difficult to pull that information out, but if you've got it associated with your system, you can access it a lot easier. So in the Attachment tab, you can attach a whole series of different files that you want, whether they be reports and PDFs or imaging files. But if you just say click on this here, which is a slide, then you can actually bring it up instantly by just clicking on the tab. We haven't done it, but you could actually point things like this to a real-time system which may be managing your imaging data, so you can actually zoom in and out, but at least having a snapshot H&E of your slide can give you some useful information. Okay, so one of the things that we want to investigate further is dashboards, and this really is about giving the end user a much better experience around it, so you can actually look at the number of patients that is enrolled in your study, the consent status, what's actually happening with the samples, and also a summary of subject study type and also visits across here. And I think this would be very useful, but as I say, we haven't actually achieved it yet. And again, here's another dashboard that would be of use. And this is really around sample tracking, so you can actually get a snapshot view of what's happening in terms of whether you have missing samples, samples that match, and also if you've got unexpected samples. Okay, so one of the difficulties about data management systems is querying systems, and in many cases if you want to do a query, you have to get an IT person to write a script to pull out that information. However, with the system that we're using a drag and drop query interface where you have a list of containers such as these here, which can be lined up, where you can then drag and pull together to pull out the information as part of your query. And you end up with the results coming out either as tables or charts. Now, to do a query like this can take you 10 minutes to do, whereas the equivalent in terms of code, which may be about 100 lines of code or more to be able to do this. And most people within the biobanking sphere don't have that IT capacity to do this. You can also do much more complex queries, and then you can also set up concurrent or ongoing reporting by doing these queries once they've been set up. Okay, so one of the just wanted to go over the user advantages. So this is about having an automated and dynamic updating of clinical data. And I think this is really, really very useful to have, because most cases the clinical data which people have on their systems is static. It doesn't get updated unless people take the time to manually update it, and usually that doesn't happen. So you can establish individual or group projects that involve clinical data and or biospecimens. It will also support multiple site or institutional projects. And really the power of it is about sort of enhancing research outputs by utilising efficient management of patient and sample and clinical data, as well as using the built-in data exploration tools. Okay, I just wanted to summarise this and say that our system, Cetus Lab Matrix, is one example of a data management system that provides a model for flexible and scalable clinical data management, and that it can really add value to and support biobanking and translational research. It demonstrates that automated data linkage is possible, but it does require good working and relationships between the data custodians and also the systems working committee, and also being able to understand the approvals pathways, which can be somewhat difficult to navigate. It provides you accurate and timely data, which really is fit for purpose for translational research. And it potentially enhances research outputs by utilising the really efficient management of patient clinical data, biospecimens, genomic and imaging data. So I just wanted to put up this list of acknowledgements, because there's a lot of people that have been involved in this work, a lot of it around the Cancer Institute BSN community of practice, with people like Deborah Marsh and Jenny and Nikki, of course, and Amanda Rush and Anna DeFazio and Susan Good, who's now no longer part of the BSN, but was a great driving force within that committee. Just wanted to thank all of the other people as well for all of their inputs and great work. Within the Ingham Institute, so we have people like Duncan and Wayne and also Joseph, who are part of the Biobank, and also the people within the Cancer Services, Nazreen and also Kifon. And I just also wanted to thank all of the New South Wales biobanking community as well. So I just want to leave you with this last slide, and it's really around the challenges of biobanking. And I think this presentation does give you an overview about what's actually happening with biobanking and also the challenges that are associated with it. I think we should have optimism that clinical data management is something that we can achieve, but there are issues, and there are issues around fragmentation and also the complex legal, ethical and governance items and the security sort of frameworks. There is also the issue about sustainability, and funding is a real issue for for biobanks, and also for the funding of data management systems. However, I think these are really very good investments for biobanking because of the fact that there's even greater and greater focus on translational research by the national funders. And I just think I'll leave it there, and we'll take any questions.
Oh, Kevin, thank you. That was a very wonderful talk. And I think probably the first question that I think people might be asking is, are you happy for your slides to be shared?
Yes, very happy.
Fantastic. Now, is anybody online?
I think, sort of really this is about sharing and all of us learning from our own experiences as well, and how we can actually move forward and make biobanking much better.
Thank you, Kevin. Does anybody online have a question? If you'd like to come off mute, and yes, please feel free to ask a question. Yes, I think Craig Getty has a question. Dr. Getty. Far away. I'm not sure if you're on mute, Craig. Let's see. Look, I might, Kevin, I had a question just about the resourcing of your project. So that looks like a really substantial project to develop the Cetus system. Could you give us an indication of how long that took and what resources you had?
Mm-hmm. Yeah, okay. So for Cetus Lab Matrix, the development of the system and all of the data linkage really has taken us about sort of 4 years. We had approvals to start doing this work in 2016. Doing the initial implementation and setup was fairly straightforward. We did go through one iteration of changing sort of the design of the system because we were concerned about any sort of data sort of read-through for the different projects, even though it may have been only sort of shell information. So we redesigned the system to make it extremely well partitioned so that there's no data crossover at all between any of the projects. The costing, yes, sort of, as part of the concept grant, the original one which was put in, which covered this work, the TCRC, concept TCRC, committed to supporting the system in its development, and it probably cost us for that about $370,000 to do this over that period of time. However, sort of the majority of that cost was around server licenses and also user licenses. We probably could have gotten away with doing it for a lot less if we hadn't been locked into a license agreement in terms of the number of licenses. That was for over a 4-year period, but we could have gotten away with a lot less. All of the work was really done by people giving their time freely, which was extra to their normal day job. We didn't have any business analysts to work on this, so sort of it was really a lot of goodwill and work by people who had an interest in trying to sort of get this system working. The hardest part of the whole thing was the data linkage and trying to get sort of all of that working correctly. Because as you imagine, there's a lot of different aspects to it and a lot of scenarios that have to be taken into account.
Thanks, Kevin. I think Craig's also asked about whether the architecture enables other LHDs to join.
Yes, absolutely. We rolled out the system over 2 LHDs just to see whether it would work and how well it would work. Certainly can link up with other LHDs as well, but clearly, there's governance and also permissions issues around doing it. So we could sort of do that. Because the way that it is, it's a web-based access, so you can be anywhere to achieve that. The other thing I suppose I didn't say about the system, it sits on the UNSW secure server, so it's outside the hospital system. But I believe that if you had this system or similar system within the hospital system, it would be much easier to do the data linkage. However, access then would be more restricted.
Right, yeah, I guess it's often a balancing act, isn't it?
Mm-hmm.
Does anyone else online have any questions?
Yeah, it's Adam Robinson here. Hi, Kevin. Long time no speak. It was a really impressive presentation. Thank you. You're within the Uni of New South Wales environment and you're feeding data from the LHDs. What did you have to go through to join all that up?
Yeah, that was extremely difficult and complex because we had to put in project application forms to the ICT, which is the Information Communications Technology within the LHD, to get them to support and approve the project to go ahead. Without that, it would be very difficult to do it because you need those approvals from the hospital side. And also they had to consider what sort of resourcing they needed to commit to the project, because clearly we had to get pathology IT to provide extracts and also to be involved in the workup for the system and how we actually did it, and also a lot of the testing as well. We also went through HREC and got ethics approval for the platform. I'm not quite sure whether it's the only data management system like this which has got HREC approval. If somebody else knows of another, that would be great to know. So, sort of like we tried to tick all of the regulatory approval systems, but, it does require also a lot of input from the data custodians, say the people who are looking after Mosaic, sort of whether it be in one LHD, you have to have that duplicated in another LHD as well, because you need that input from their end.
Okay, but your underlying assumption in all of that is that data is picked up out of an LHD system, moved into presumably a file, transferred across, and then stored, housed, and processed in the Uni of New South Wales system.
Yes.
So, for example, if you wanted to approach private pathology suppliers for their path reports rather than an LHD, you could do that using the same architecture.
Yeah, absolutely. One of the things that we used was the EMR approved Kiteworks app, which is a sync and share app. And the reason why we basically had to go down that route is that to do a secure FTP, that is not something that is supported by New South Wales Health, because that gives you a direct link and continuous link into their systems, which I think becomes a security risk for them.
You've just hit the exact problem I'm sort of contemplating at the moment. Thank you.
Kevin, I can see a question online from Mark McLean, whether you plan further improvements and about sort of system maintenance and integration.
Yeah, I think, the system is continuously evolving. Clearly, the thing around dashboards is something that I think is particularly interesting and useful. We don't have those dashboards yet, but it would be something that I think would be a great improvement in terms of the end user ability to interact with the system. We can also develop new data loaders for pulling information from other systems. The nice thing about Cetus Lab Matrix is that the ability to create those data loaders is fairly straightforward from the system's end. It's getting the linkages from the other end and setting up the routine data extracts from the source systems is the difficult part. But yeah, you know, we can continuously improve. And the other thing is that we have basically created templates for different activities such as biobanking and translational research projects for registries and also clinical trials. So we've made electronic CRF forms which then could be adapted for sort of different studies and used as a base. So actually cut a lot of work out by having those templates already available.
That sounds fantastic. I mean, are those kinds of resources, are they sort of relatively easy to share between platforms, or are they quite specific to Lab Matrix?
I suppose it's fairly specific to Lab Matrix because of the way it was designed in the first place. So it has a huge amount of functionality and capabilities which I don't think we've even scratched the surface of. You know, I won't pretend that sort of I know everything about the system. I know a reasonable amount, but not everything. And Duncan knows much more about the system. He's a health informatics person, which I have working with me. But I think sort of the biggest challenges about any of these sort of systems is sustainability of funding, sort of, and getting institutions to support them. But I always thought that would have been in their interest, sort of because protecting clinical data is incredibly important.
Look, it sounds like a fantastic system. I've just got one last question from Craig Getty. Just as New South Wales Health moves towards unified EMRs, mostly under Cerner, will your platform be able to adapt?
Yes, absolutely. Because all that would require would be to set up a new data loader to pull any information from the new Cerner system. Because I think Cerner does power chart as well, so sort of setting up those extracts, and whoever is the data custodian at the other end is the important sort of thing.
Look, I think in the interest of time, we might wrap up, but Kevin, that was really a wonderful talk. I enjoyed it. There were lots of people with me here all nodding at different times, and I can see from the attendance today that speaks volumes to, I think, the interest in your talk, and I think the information that you presented is going to be really valuable to many of the people who dialed in today. So thank you again so much. And our next talk will be next Monday, and that's Professor Nick Sepps from Melbourne. We've got a bit of a run on data and consent, so please join us next Monday. But also thank you so much, Kevin, for a really great talk today. So